Welcome to week 9. I know it seems a little weird because you already had your lecture day, but it was a test taking day and we were on campus. So, first off, I have to applaud all of you. That was a change that was kind of unforeseen from all of us, including myself. But I was really taken aback at how well and how professional everybody was. They came on campus, nervous, understandably, but prepared. Everyone was able to disseminate between 2 rooms, get used to the adjustment that using a different computer. We had a few minor technical glitches, but honestly, I think nothing compared to what we have on a typical day with Respondus. So with that being said, they were minor. We were able to get through it, and that's the important thing. So I do want to relay some of the statistics that I got from it. I know some of you are concerned. It was a difficult test. I will agree with you on all of that. However, overall, both groups averaged 84% on that exam. It actually mirrored the online bell curve that we have. So congratulations to all of you. Those of you who didn't do as well as you wanted to, again, it's a 3 exam average. So you might just have to study a bit harder for that final exam, which is cumulative. And again, if you want to figure out what grade you need on that final exam, it's a calculation that we can do. Let me just type that in here so you can do that. So it's going to be 234 minus the percent you got on exam 1 minus the percent you got on exam 2. And that will equal what you need to get on your final exam. So, and the number, if it's big, I understand that. It doesn't mean it's unattainable. That I can't emphasize enough that there have been people in anyone's situation where they needed a very large number in that final exam and were able to pull through. Again, I'm here as a resource. We'll go through study material and we'll make sure that we get it for you. So good. The last thing I want to put in before we start into this week's lecture on environmental emergencies is be sure to put in your ATI remediation. It's 65 points. That's a lot of points to get in. And at this point in the game, any points count towards you. So please do that. I don't want to rob you of any of that. So with that being said, let's get into our common environmental emergencies. So, and again, as you saw here, the content we're going to go over in this one is hyperthermia and signs and symptoms, interventions, heat exhaustion, heat stroke, and then our hypothermia, the opposite end of the spectrum. What do we see with that? And what are interventions with frostbite and frost nip, for that example? And then drownings. We have saltwater drownings, and here in Florida, this is huge, and freshwater drownings. Unfortunately, one of the larger categories of patients I've flown over the years here have been drowning and near drowning patients. So let's start with hyperthermia. Again, we live in a sunshine state. We would expect to see hyperthermic patients, and we would be remiss to say if we don't know how to recognize them and intervene with those patients. Pardon me. So first off, let's quantify it. Hyperthermia is temperatures greater than 105 degrees Fahrenheit. It increases the cerebral metabolism, and you get a risk of hypoxia with it. Signs and symptoms that you see with that are early on agitation, confusion, stupor, and coma. Again, early signs of hypoxia. You get vascular collapse. That can lead to cerebral edema, shock, and death. And death usually results if the body temp becomes a little bit higher than 109 to 112 degrees. Causes can be a myriad of things. Exposure to high environmental temperatures, and that can't just be outside in the desert or sitting on the beach all day. That can be environmental temperatures inside a factory that's not well ventilated, inside storerooms. Something like that can lead and tend to hyperthermia. Cars is a big one, hyperthermia. We see that with these infants and children that are locked in cars and succumb to that a lot, unfortunately. Infection can have it. Dysfunction of thermoregulatory functions. There could be pituitary problems. How do we treat it? Well, ABCs always. We maintain patent airway. And with this particular population, we want to initiate seizure precautions. Again, we have a sodium imbalance with some of these hyperthermic patients as they sweat excessively, and we have that imbalance. Induced normothermia, we can do that with fluids. If they're awake, alert, and have a self-maintainable airway with an intact gag reflex, we can have them drink cool fluids. We can give them cool baths, fans, or even hypothermia blankets. There's things called Arctic Sun. There's a lot of different proprietary items on the market. And if you've done clinicals with me, sometimes at Advent Health, we've actually pointed those out. We want to monitor their intake and output. We assess their skin, mucous membranes, lung sounds. And of course, we always look for dysrhythmias because we're going to have electrolyte abnormalities. We really want to prevent shivering, though, because when you shiver, the whole purpose of shivering is to increase temperature. So it increases intracranial pressures, oxygen consumption, but it elevates the temperature also. So it kind of is counterproductive for what we as clinicians want to do with the hyperthermic patients. We can give them certain medications, muscle relaxants. We can give them some benzodiazepines. And we want to monitor that neurostatus. Again, we want to make sure that those electrolyte shifts aren't corrected too quickly because that can lead to imbalances, and that we recognize if there are deficiencies and treat the underlying cause. If they're sitting in the hot sun, take them out. If they're in a hot car, take them out. Remove that offending agent, much like the burn patient we spoke about. They're going to keep burning if they're stuck in the fire. So remove them from that environment. We talk about the illnesses related to heat, and the most common factor of heat-related illness is environmental temperatures over 95 degrees Fahrenheit and humidity about 80%. Well, basically Florida for about 8 months out of the year. So we are really at the top of the line because we hit the most common factor of heat-related illness. It leads to heat exhaustion. That's number one, and heat stroke if it goes unrecognized. So the patient's health can increase the risk for heat-related illnesses too if they have underlying causes: obesity, heart disease, infection, if they have seizure predisposition, mental health disorders. And the reason that, because some of the medications will predispose them to that. And of course, burns. So let's talk about heat exhaustion. And that's a syndrome. It really results from dehydration. Okay, it's caused by heavy perspiration. That's a hallmark of it. Inadequate fluid and electrolyte intake. And during the heat exposure over several hours, sometimes several days, if it goes unrecognized and it's innocuous and insidious and slow enough. The heat-related illness is common environmental emergency. We do see it quite a bit. It affects the most vulnerable at-risk populations, such as older adults and those who work outside, the homeless, and athletes in training outdoors. We have this wonderful thing in Florida, many wonderful things. They're called amusement parks. We see this happen a lot because who goes to the amusement parks? The at-risk populations. A lot of children go there, and usually they're going with some adults or older adults. The homeless population, depending on what city you're in Florida, can be very proliferative, and we can see a lot of that happening. And of course, the athletes. There isn't a summer that goes by that we don't hear of an athlete, high school, middle school, collegiate, that drops on the field from profound dehydration and heat exhaustion, sometimes even heat stroke. We have certain conditions or medications that a person can take that increases their risk for illnesses related to stroke, to heat. Benzodiazepines, calcium channel blockers, actually. Laxatives, they're going to dehydrate them. And neuroleptic drugs can lend themselves to that. Thyroid agonists, Synthroid, you're increasing the basal metabolic rate with that. So keep that in mind when you're dealing with patients who have underlying health disorders. So when we look at the differences, though, between heat exhaustion and heat stroke, it's important that we recognize the differentiation between them. So heat exhaustion, simple. It's excessive heat and dehydration. They're pale, they're dizzy, nausea, vomiting. Think of a hypovolemic patient and hypovolemic shock. They have that same mentality. They're dehydrated, they're hypovolemic. They may faint. They have an increased temperature, usually 101 to 102. It's not profoundly severe. Heat stroke, on the other hand, is the opposite. They're warm. They're flushed. They don't sweat. That mechanism has completely shut down in their body. They're dry as a bone and red as a beet. They have temperature sometimes greater than 106 degrees Fahrenheit. Neurologic changes, altered mental status, seizures, coma, and death. I took care of a patient. I was in Memphis, Tennessee. I was working in an emergency department. It was a travel assignment there. They brought this gentleman in, EMS, and he had a temperature of 107 degrees Fahrenheit. He was seizing. He had second degree, full partial thickness burns to his knees, his elbows, his forearms, his forehead, because he was slumped over on the steering wheel in his van with no air conditioning on in the heart of a southern summer. So he was profoundly in heat stroke. He had massive electrolyte derangements, and he wound up getting intubated, and I can't even tell you what happened to him. It wouldn't surprise me if he did not succumb to that with death, because he was in that vehicle for such an unknown amount of time, but prolonged enough to really draw him out to this. And again, I'll never forget that heat stroke patient as it's vivid in your mind. And I think we spoke about this, some of us in clinicals, is that, when we're doing the didactic work, once you see it in real life, after you read it in a book or hear it in a lecture, that's when it connects. And that's where your learning is really going to take off as nurses. Once you're out there practicing and you're like, yes, I remember hearing about heat stroke. Now I see it. Just make those connections. So heat exhaustion causes that physical exertion in a hot environment. And in a hot environment, due to dehydration, they get hyponatremic. Symptoms are flu-like, achy, headache, weak, nausea, vomiting. And if it's not treated, it will progress to heat stroke. Again, that's one of those things, if we can intervene early, it's an early sign. Let's get them out. Let's cool them down. Treatment, stop the physical activity. Remove excess clothing. Move them to a cool place. Cold packs on the neck, chest, abdomen, and groin. Why do you think we would put them on those specific areas? And if this was a live lecture, I'd hopefully get some answers that, you know what? The neck, the groin, the armpits are all major arteries. The carotid arteries, the femoral arteries, the axillary arteries. When we put ice packs in there, that circulates that coolness through the body, and it kind of indirectly is a thermocooler of the body by cooling off the blood in the major vasculature that we can actually put cooling blankets over. The chest, too, a large surface area. The great vessels lie underneath there. It's all about cooling the entire body and doing it smart. Fan the victims, cool and assist. Again, evaporation, conduction. There's a lot of different ways that we can cool people down. Give them sports drinks. They have electrolytes to replace the sodium. Again, we don't want to give them pure water because they're hyponatremic. And if we give them too much, then it's water intoxication. And that leads to, hopefully recall back from pathophysiology and even early in this course, that can lead to cerebral edema, seizures, coma, and death. So plain water may deplete that sodium further, and if there's no improvement, transport them to a local hospital. Because in the hospital, they can monitor the vital signs first off. They can give them intravenous supplementation, and they can assess the lab values. They can look at the electrolytes. They can see what derangements are there. And if they need to cool them off a little more, they have specialized equipment like cooling blankets. Heat stroke, on the other hand, is a true medical emergency. The body temperature makes it 104 degrees Fahrenheit. The thermoregulation mechanism, it fails. It can't adjust to the elevated body temperature. It just doesn't know what to do. So the signs and symptoms, again, they're hyperthermic, they're hot, they're dry. They may or may not perspire, and usually they don't perspire. Does not mean that their clothes might be wet, because they, again, heat exhaustion leads to heat stroke. They perspire in heat exhaustion. They stop in heat stroke. So if they have a wet clothes, their skin is what you're assessing on them. Mental status changes can range from confusion, anxiety, all the way up to hallucinations, seizures, and comas. They get hypotensive. Again, they're hypovolemic, tachycardic, cardiac dysrhythmias, and tachypnea. Electrolyte imbalances, again, hyponatremia, hypokalemia. And those two, we look for neurologic disorders, and we look for cardiac manifestations, particularly electrocardiographically. Decreased renal function. They get oliguric, it shuts down, and they get coagulopathies. They can start clotting, actually. Pulmonary edema is not uncommon. So what do we do when we know somebody is in heat stroke? Well, again, ABCs. Always start with the ABCs. Airway, breathing, circulation, make sure that's patent, that they're breathing adequately, that it's sufficient. We give them IV fluids, normal saline. And the good thing is we can cool that fluid. We can give them cooled saline intravenously to slowly regulate that body temperature down. We don't give them any food or water because we don't want them to aspirate. Again, they're having mental status changes most likely at this point. A Foley catheter to monitor output. The other thing on the picture on the upper right here is that Foley catheter is also an indwelling thermometer. So we can get a full core temp on that patient, which is phenomenal. And it's real time. It sits in that urinary bladder. We can get the true temperature of that patient 24/7 as we're monitoring that urinary output. We can also cool interventions. We can do rectal temperatures in addition to the Foley catheter thermometers. We prevent shivering. Again, we know that increases temperatures. But if it does occur, we can treat that pharmacologically. We give them benzodiazepines like Valium and Ativan, and that'll actually cease that shivering motions. Again, those are the same medications that we would give for a seizing patient. Again, we're giving it just for a little bit different level. It's not as severe, but the mechanism of action's the same. We use cautious core temperature monitoring, such as rectal esophageal probes. That's one thing that we can do. We can put an esophageal probe. Again, it's all about core temperatures, and the urinary bladder, which we spoke about. So we monitor the CBCs, again, coagulopathies. We look for, and again, They're dehydrated, so we would expect a high hematocrit, a high red blood cell count. All of those things increase a high platelet count. Chemistries, cardiac and liver profiles, because untreated, it can progress down into shock and thus MODS, which you spoke about earlier, and ABGs and EKGs. So what are the techniques that we have for hyperthermic patients? So evaporative cooling, sticking a fan on them, make sure they're cool. You can have a moist towel, a blanket on them, and that fan blows that, and it's an evaporative cooling. The ice packs to the axle and groin and the neck, as we spoke about earlier, and cooling blankets, of course. Those can be proprietary in nature, and those can be a little bit more aggressive. We can do something more invasive. Now, these are non-invasive when we go back here. It's a non-invasive way. I can do it. You can do it. Any bystander can do this stuff to patients, minus a cooling blanket. But then we have invasive ways to cool them. One is a gastric lavage. We can take cool fluid, we can instill it through an OG tube or an NG tube, and we can lavage that stomach. And again, it's an internal cooling. We can do bladder irrigation. It's the same thing. We're going to continuous bladder irrigate with cool temperatures. They also have new techniques that do intravascular cooling to such a precise level that you can type in what temperature you want that blood to be at, and it'll do that for you. It's phenomenal. So that's about our heat-related emergencies. And they probably should sound familiar to you, which is good. Again, the way that MDC4 works is it's all building on knowledge now we're just kind of putting it together. We knew about hyponatremia. We knew what the causative factors are. We knew what the manifestations are. Now we have disease states to kind of couple it with it. Let's go to the opposite extreme and talk about cold. And I know what you're thinking. We live in Florida. We don't get hypothermia, but that's untrue. Actually, our core temperature is 98.6, and in the wintertime, as it is now, it's cool. And that water temperature, even submerged for a little bit of time, can drag your body temperature down to hypothermic levels. So the definition is a core body temperature below 95 degrees Fahrenheit or 35 degrees centigrade. And the causes of it, of course, cold water immersion, that is a big one for us. Acute illnesses such as sepsis. And we spoke about that last module. We talked about, hyperthermia and its predictive possibility, mortality, morbidity, but we know that hypothermia is much more indicative of poor outcomes for those patients. Traumatic injuries, shock states, immobilization, neurogenic shock we spoke about. We really have to look at thermoregulation for those patients. Cold weather, wind chills, wet conditions. Again, as you're wet and you're out and it's windy, you've all been in that sort of day, it really, now you're getting evaporative measures on top of direct cooling. It's a lot of things, and pseudo-immersive if it's raining too. So you're getting cool by multiple ways of conduction. Advanced age, again, their thermoregulatory mechanisms aren't as robust as a younger population. Alcohol intoxication and substance abuse. Again, alcohol is going to be a vasodilatory effect. You're going to lose that ability to conserve heat. And then substance abuse. It'll also the mentation changes. So you're not acutely aware of your body's signals saying, hey, it's cold. Maybe you should put something on. Malnutrition, obviously, if you don't have enough meat on your bones, so to speak, you'll lose heat a little bit quicker. Hypothyroidism, we spoke about that before. You have everything slows down. So they're very cold intolerant to begin with. And now you add that layer of ambient temperature or an environment that's facilitating hypothermia, it's going to manifest a little bit quicker. An environmental temperature below 82 degrees can produce impaired thermoregulation and hypothermia. That's crazy. 82 degrees, it's 82 degrees. 82 degrees is still less than your internal body temperature. So it's really important to note that can really impair your thermoregulation. So what's our physiologic responses to this? Well, our hypothalamic sensors detect cold. And in an attempt to increase heat production and minimize heat loss, we shiver. And again, that's why neonates don't shiver. They don't have that mechanism to burn brown fat, but adults, we do. We shiver. It releases epinephrine. It increases metabolism. So you get vasoconstriction, shunts blood away from the periphery. That's why your fingers and toes and nose and ears get cold first. Those are peripheral. So that's what clamps down first. A piloerectation, goosebumps. Those hairs stand on end. So those erector pili muscles in there that will cause those goosebumps and that piloerection increase the hair out. So it's an insulator. That's a vestigial response we have from way back when. Piloerection puffs of air, furry mammals making cold animal warmer. So you see that. You see a dog or a cat when they just get cold and their hair puffs up. So we can stage hypothermia, and we look at the signs and symptoms of it. Mild, shivering, slurred speech, decreased muscle coordination, mental slowness. They may diurese, causing by shunting of blood to major organs. If we get to the moderate stage, there's muscle weakness, increased loss of coordination, acute confusion, apathy, incoherence, stupor, decreased clotting caused by impaired platelet aggregation, and thrombocytopenia. And in those severe cases, they get bradycardic. They get severely hypotensive. They decrease their respiratory rate. Their cardiac dysrhythmias manifest, and they're all ventricular. They're usually VFib early on and asystolic later. They decrease neural reflexes, decrease pain response, and acid-base imbalances. It's funny, these severely hypothermic patients, as they translate between moderate to severe, are often found naked, where that mentation and that stupor makes them think that they're warm, and they take their clothes off, which unfortunately further propagates the signs and symptoms and the progression to severe. So how do we care for the mildly hypothermic patient? Well, we provide a warm environment. That makes sense. We provide dry clothing, apply warm blankets, keep the limbs close to the body. Again, it's all about surface area. Cover the client's scalp. Again, that's where we have a lot of heat loss. Your scalp is profoundly vascular. It can get a lot of blood loss through there for the laceration. And the same thing goes with heat loss. Again, if we cover that, we can retain heat. Supply warm oral or intravenous fluid. We can do the opposite of what we did for heat stroke and heat exhaustion. Apply warming pads. And again, you can apply warming pads to the groin, to the armpits, axilla, for the same reason, chest and abdomen. It's warming up the blood at this point. They have hypothermic blankets, warming blankets. They have them in the operating room too, because we spoke about that the patient needs to be monitored for hypothermia in the OR. We avoid alcohol, caffeine, and diuretics. And how do we care for the moderate to severe hypothermia? Well, it's a little bit more invasive. So we handle them gently. Place them supine, assess orthostatic changes, monitor for cardiac dysrhythmias. That's really important. We really need to be one step ahead of these patients. Again, ABCs, we may have to do CPR. And that's the old adage. And I know the medics out here know this, that you're not dead until you're warm and dead. And there's cases where people have been on cardiac arrest for hours and have made it, not only survived with ROSC, which is return to spontaneous circulation, but neurologically intact, awake, alert, talking, CPC, cerebral perfusion category scores of 1 or 2 with no or very mild neurologic deficits. So that's why when we have a hypothermic cardiac arrest, we really go that extra mile to work them and work them, make sure we warm them, because again, they're not dead until they're warm and dead. But then we worry about after drop. So if we get circulation back, we really have to be cognizant at this point, because as that blood starts moving through their body at a normal rate, all that peripheral blood is cold. That periphery is the first thing that shuts down. So as that starts to rewarm and revascularize, all that cold blood comes back into the core and can further drop that core temperature. So just because we get them back, it's no high fives. We really got to watch out for that. So it's that continuous drop in core temperature. And we just spoke about that. Therefore, the trunk should be actively rewarmed before the extremities. Again, rewarm the core. What's in the core? The heart. That's the important thing. Moderate hypothermia, core rewarming methods, we can just administer warm IV fluids, heated oxygen, inspired gas, heated humidified, heated peritoneal, pleural, gastric, or bladder lavage. So we have all of these compartments. And peritoneal lavage is not uncommon. For traumatic patients, or before the advent of a fast exam with ultrasound, we used to do a diagnostic peritoneal lavage between the umbilicus and the pubis, make a little incision, put a catheter in there, instill some fluid, then drop the fluid, whatever comes out. If it's bloody, it's positive. We take them to the OR. But we can maximize in that omentum. That omental layer is very vascular in there, so we can instill warm fluids in that peritoneal cavity and rewarm them very invasively. In severe hypothermia, they may have to do extracorporeal rewarming methods, such as cardiopulmonary bypass, which is the fastest way. Again, it's removing the blood and not only oxygenating it, but rewarming it through a machine and putting it back in. Or hemodialysis also works for those patients. So what about therapeutic hypothermia? You've all heard about it. It made its kind of premiere from a football player who got tackled and went into spinal shock and did not go into neurogenic shock, but was a cervical spine injury. And they instituted therapeutic hypothermia. They brought his core temperature down. The theory behind it was it'll kind of minimize the amount of inflammatory damage. So it helps reduce the risk of tissue injury from a lack of blood flow. It slows the metabolic rate of those cells. So clinically induced hypothermia can improve the neurologic outcomes of unconscious patients after sudden cardiac arrest. So we know that. Current evidence suggests that early use of mild hypothermia therapy in select populations of patients improves survival and neurologic outcomes. So there's a great overview of therapeutic hypothermia on this link here. I encourage you to look at it. But I want to put the caveat in here. Therapeutic hypothermia was really, really hot and heavy about, say, 5 to 8 years ago, to the point where it was instituted in a lot of pre-hospital environments. So the ambulances would start therapeutic hypothermia. Unfortunately, they didn't have the true means to maintain that hypothermia en route. And when they get to the hospital, then the hospital had the better equipment, like we spoke about, this thing called Arctic Suns or whatever, that would intravenously maintain that hypothermia. But in that interim period, the patients would rewarm and then cool them. What we found, evidence-based wise, is that that is more detrimental than not starting hypothermia at all. If you cool them down, warm them up, and cool them down again, they tend to have poorer neurologic outcomes from that. But anyway, it's fascinating to listen to that. So I encourage you to read up on that. So let's talk about some of the other things that we come across. Frostbite and frost nip. So frost nip is a superficial cold injury. It produces pain, numbness, pallor, this kind of waxy appearance, easily relieved by applying warmth. Typically face, nose, fingers, and toes. Again, everything that clamps down initially first off. So the degree of frostbite, it's kind of like burns. You have a first degree, it's a hyperemia, it's red, and it involved area, and there's some edema formation. Second degree, it's clear to white milky fluid-filled blisters. Sounds very familiar to burns. Again, as it progresses, it's pink, then it goes to blisters. Third degree, there's small blisters that contain dark fluid, which is some myoglobin, an affected body part that is cool, numb, blue, or red, and does not blanch. When it doesn't blanch, it's not getting blood flow, and that's the problem. And full thickness and subcutaneous tissue necrosis. It requires debridement. And again, you can look to the right there, and you can see the progression of some of these. That's the first, frost nip, first and second. And then there's fourth degree, which is the most severe form. There's no blisters or edema. The part's numb, cold, bloodless. Full thickness necrosis extends into muscle and bone. They get gangrenous, which can get them to be septic, and they usually require amputation. And all degrees may look alike. That's the thing. So it's after the area is thawed that the degree becomes apparent. So gangrene may occur sometimes days to weeks after the injury. But just because it looks good now doesn't mean it's going to look that way in 1 day or 2 days. And again, this fourth degree on the right picture there, it's no joke. I mean, that's bone sticking through. It's completely eaten away. So for all the degrees of partial thickness to full thickness, a rapid rewarming in a warm water bath. Temperature is about 104 to 108 degrees Fahrenheit, and it's to re-thaw the frozen part. They have extreme pain when it starts to come back. Wait to complete this until they're at the medical facility, unless there's really no other option. So that's where they're going to give them some IV analgesics, rehydrate them, but mainly to help them tolerate this rewarming procedure. Anyone's been out there and had a frozen hand or feet or anything that it starts to come back and that's tingly pain, it's noticeable. Again, they're going to start them on some anti-inflammatories like ibuprofen. And look at that, every 8 hours, it just decreases that inflammatory cascade. Again, it's damage to tissue, and we know that from almost every module that we've been in, that there's always capillary permeability changes with tissue damage, and there's always going to be some sort of edema and inflammation cascade with it. So when the rewarming is complete, we gently elevate that injured limb above the level of the heart if possible. We want to reduce edema. The splint may be applied during the healing process, and we assess hourly for compartment syndrome. A lot of common themes you're hearing in MDC4. Compartment syndrome has manifested in several parts, and here it can manifest also in cold injuries. Again, pallor, lack of pulses, pale, pulselessness, paresthesias, so all of that you're looking for. Muscle weakness and pulses. Compare color with the unaffected extremity. And again, the life-saving tetanus, and apply any loose, non-adherent sterile dressings to the damaged area. We're not really tightly wrapping these. So we avoid compression of those injured tissues. We want them to revascularize. Topical and systemic antibiotics may be performed. And for severe deep frostbite, it requires debridement of necrotic tissues. All of this sounds very, very familiar, very, very indicative because it very, very much mirrors the burn patient. Amputation of gangrene or severe compartment syndrome occurs. And again, if they have compartment syndrome, they will get a fasciotomy to relieve that pressure. Same as what we would do if the escharotomy didn't work on a burn patient. But once it's thawed, it's really important we don't allow that part to refreeze. That'll just completely worsen the injury. All right. Any questions on that? I'm going to say no because I'm recording this. Well, let's move on to drowning. And this is very prevalent, and if you work in emergency medicine or critical care medicine or sometimes pediatrics in the healthcare system, you will come across a drowning or a near drowning patient. It's an aspiration of both fresh water and salt water. It causes surfactant to wash out of the lungs. It destabilizes that alveolar capillary membrane interchange, and it leads to increased airway resistance. What also had surfactant washout? ARDS, acute respiratory distress syndrome. When you start messing with surfactant, it's very difficult to treat those patients. But keep ARDS in mind when we're talking about treatment of near drowning patients. So saltwater aspiration is hypertonic. So the inhalation of saltwater creates this kind of osmotic gradient, and it draws protein-rich fluid from the vascular space into the alveolus, so they get pulmonary edema. Freshwater aspiration may cause just fluid volume excess, but not necessarily fluid shifts. However, both salt and fresh water cause alveolar damage and pulmonary edema. That is a fact. When you wash out surfactant, whether it's salt or fresh water, it damages the alveolus and you have pulmonary edema. So think of that when it comes to treatment. Two most important factors that determine outcome of drowning victims: the duration and severity of the hypoxia. Very cold water kind of has a little protective effect, though. Successful resuscitations have occurred after prolonged cardiac arrest. That is the truth. I've been part of those, where you're doing cardiac arrest for a very long time for a drowning or near drowning patient. Well, it's a drowning patient until we get them back with little to no cerebral issues. So reduced cerebral metabolic rate, it's protective. It's that hypoxic brain gets protective. There's a thing called a diving reflex, and it's a physiologic response to asphyxia. You'll hear a couple of different definitions of the diving reflex. So this particular definition is talking about producing bradycardia, leading to a reduced cardiac output. Pardon me again. Causes vasoconstriction of the intestines, skeletal muscles, and kidneys. It reduces myocardial oxygen and enhances blood flow to the heart and cerebral tissue. Reduces myocardial oxygen consumption. Survival linked to a combination of the effects of hypothermia and the diving reflex. Another thing you'll hear about the diving reflex is strictly in pediatric patients. It's not in adults. It's when they're submerged in very cold water. It's actually a spasm where the epiglottis covers the glottic opening to prevent aspiration. So we talk about, why did the patient drown? That's really, really important for us. It's not just that they're a near drowning or drowning patient. Is what caused it? Was it a medical issue? Did they have an MI, a stroke, a seizure that forced them to fall into the water? Did they dive into shallow water and now have a cervical spine injury? You need to consider other injuries or medical issues. And I'm pretty sure I told this group before a call that I flew in on, and it was up here in Florida. And we got called to two brothers, two of them, that drowned in a river. And one was face down, one was face up. And when they pulled them out, obviously CPR is performed. They were both got return of spontaneous circulation. Both of them were in very bad shape. But the one who obviously was found face up did a lot better than the one who was face down, who didn't do as well because he had a much longer period of anoxia and hypoxia. The root cause of their injury was lightning struck the water, and they both got electrocuted. And that was really found is when we put a Foley catheter in them, and both of them had this profound rhabdomyolysis, this myoglobin area. But that was the cause that caused them to drown. So now we also had to treat an electrical burn on top of this hypoxic drowning and near drowning event. Very important to consider that. So there's terms need to be important that we no longer use when it comes to drowning. We don't have this wet drowning, and that's where it's the drowning sequence. Laryngeal spasm occurs by water entering the upper airways. In most drowning cases, the spasm relaxes, water enters the lungs. Historically, this is what we called wet drowning. And then they called it dry drowning. This is where maybe a handful of drowning cases that laryngeal spasm does not relax and no water enters, and they become hypoxic. So they dry drown. There's no clinical difference between wet and dry drowning, and the distinction does not affect patient treatment or outcomes. So if you've heard that before, forget about it. Talk about drowning interventions, though. C-spine immobilization, because we don't know what caused it. Maybe they dived into shallow water. So diving board accidents, shallow waters. We clear the airway, suction, 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 assess breathing, start CPR if necessary, monitor for cardiac dysrhythmias, okay, ventricular fibrillation, something that we can treat electrically with defibrillation. With the old OMI, oxygen, monitor IVs. NGOG, we really want to pull whatever's out of their stomach because it'll do several things, whether it's air, aspiratory, whatever gastric contents are in there. It's also going to decrease the intra-abdominal pressures and allow for better aeration of the lungs. After CPR medication, the patient will develop a distended abdomen, and it impairs movement of the diaphragm. That's exactly what it does. The full spectrum of critical care technology will be required to manage the pathophysiologic complications of drowning, such as care for pulmonary edema, infection, ARDS, CNS impairment. When you look at that, pulmonary edema, ARDS, what's the main thing we do for both of them? PEEP. We're going to give them positive end expiratory pressure, keep those alveolus open, force the fluid in them out. Infection, we're going to probably start them with some antibiotics. And CNS impairment, it's going to depend on the degree of that and what the etiology that was, whether it was trauma or hypoxia. Then we have to do prevention. So the leading cause of accidental death in the United States, it's sad. Prevention is the key to avoiding drowning incidents, so don't swim alone. Constantly observe people who cannot swim or in and around water. Know water depth before diving in. Avoid drugs and alcohol before swimming or boating. And ensure that water rescue equipment such as life jackets, flotation devices, and rope is immediately available. I'm going to show you two videos because I like to show videos. And they tend to be pretty poignant. So these particular videos, the first one we're going to play, Find the Drowning Child. This is in a pool. It's a public pool. There are lifeguards present all the way around. And I want you to try to find the child who's drowning before the lifeguard does. So here we go. A lot of people there. 1, 2, 3, 4 lifeguards. Where's the drowning kid? Do you find him yet? There we go. Have you seen him? He's right here. Did you find him? Were you able to spot him before that lifeguard did? It's amazing because the key thing is it's difficult. A lot of people think that there's this loud, dramatic event when they're drowning. Most kids, sadly, drown in silence, which brings me to my second video. This one's hard to watch. This is a child who drowned in a fountain pool. So, unmonitored child trying to get something in that pool. I think it was a ball. No one's around. This is the importance to underscore supervision. Again, this child wandering around, still trying to get whatever was in that fountain where people are walking around. And you saw somebody walking earlier. And it just takes a half a second. One misstep. There's no screams. There's no major splashing event here. This is a very young child that is slowly drowning. And about a full minute later, child, unfortunately, is still not upright. There's movement, which is a good sign, but still nothing. It's difficult to watch till the little brother comes. Doesn't know what to do. Older brother points out to mom, help, help, help. Mom finally gets the baby out, but it's really, really important to know how quickly it can happen and how silently it can happen. I know those are tough videos to watch, but it's important because I think we all think we know what we can see with a drowning patient, but that's not the case at all. We like to think we know what's going to happen, but quite oftentimes we don't. So hold on, let me drop this. All right, so let's get back into disaster preparedness as far as the hospital is concerned. So hospital preparedness for disasters, there's internal preparedness. That's an event occurring inside a healthcare facility that can endanger the safety of the patient, staff, and the visitors. Fire, flooding. Events cause a need for evacuation or relocation. So it requires extra personnel and activation of the facility's emergency preparedness response plan. Those of you who work in a hospital are completely aware of what this is because you've probably been involved with it at one point or another. These are fires, explosions, loss of critical utilities such as electricity, water, computer systems go down, communications, violence. That's a sad part of reality today. The goal is to maintain patient, staff, and visitor safety. That's really the goal. And then we have external preparedness. That's an incident that occurs outside the facility. It requires activation of emergency management plan. Extra staff are called in. This is earthquakes, tornadoes, terrorist attacks, hurricanes, because we live in Florida, and both internal and external disasters. So St. John's Regional Medical Center in Joplin, Missouri, back in 2011, it was directly hit by an EF5 tornado. That's what this picture is of. It destroyed much of the town. 142 people died. 6 people inside the hospital died. So those are real internal, external problems. So let's take a look at the internal hospital disasters. Available hospital resources versus volume of sick and injured. That's what we need to know. The facility characteristics, the faculty characteristics. So the hospital size, the advanced preparation and training, the number of ED beds, radiology resources, OR suites, number of critical beds. It's all comes in to see how is this going to be overwhelmed. We pre-establish response plans. We have an incident command system, which assigns responsibility, communications. We restructured for the hospital, so we have a hospital emergency incident command system. And we look at the key players involved in that. So in our incident commander is the one who's kind of in charge. That may be a physician, administrator. They assume the overall leadership for implementing this emergency plan. Then we have our medical command physician. This is the physician who determines the number, acuity, and resources needed of patients. We have our triage officer. This is a physician or nurse who rapidly evaluates each patient to determine the priorities for treatment. And it's important to know that a patient who's triaged in the field might be triaged very high in the field, might be a lower triage category in the hospital depending on what other patients are around. So there's always a need for a re-triage. Community relations and public information officer, people are going to want to know what's going on. People are going to want to be informed. So they serve as that liaison between the hospital and the media. So how do the hospital prepare for this? For hazardous materials, we always have a decontamination plan in place. Biological warfare and biological agents, we want to reverse isolation rooms, and COVID has really ramped up. Almost every hospital in the United States to have that. Negative pressure rooms, HEPA filters, where before it really wasn't that common. You had to have maybe one room. Personal protective equipment, blast injuries, blast injury patterns. We look at that, there's primary, secondary, tertiary, quaternary issues from blast injuries. And what was it? Was it a strict explosive? Was it a dirty bomb? Is it a radiologic condition now? So all those patterns come into play with it. Stress reactions. There's PTSD. There's CISD teams, critical incident stress debriefing teams. If anyone's been part of a very traumatic event, you know the importance of that. So when we talk about hospitals sometimes have to be evacuated. From 2000 to 2017, natural threats, the most common was hurricanes, wildfires, floods, and storms. Intentional disasters, bombs, bomb threats, followed by armed gunmen. The most frequent infrastructure problem, fire and smoke, chemical fumes, without a doubt. And you can look at that here on PubMed. That's evidence-based. So I'm going to give you a little story here of one. Hurricane Charlie, if you remember here in Florida, we had one year where 4 hurricanes came right through Florida. Hurricane Charlie went straight up to Port Charlotte. My entire 10-year and 20 years flying in Florida, I flew in every hurricane I was on duty. And this one, we went down to Port Charlotte, and we went into the hospital there, and it was a disaster. The whole first floor was flooded, and we were evacuating the critical patients out of the intensive care unit because they didn't have anywhere to treat them. The staff were there for days. They had MASH tents out front from FEMA, and we would just take multiple patients at a time in the helicopter just to get them to a real hospital that had everything that hospital had destroyed, all the windows blown out. Really horrific event, but that is a true hospital evacuation that was done with a army of ambulances and aircraft. So what's the responsibilities of a nurse manager when this happens? So they prepare a list of clients who can safely and quickly be discharged. Again, knowing what you have. If they're minors, re-triaging your department, get them out. A list of staff who can be sent to command centers if required. So sometimes we have to go outside the hospital and to start to pre-treat what we can treat and triage. Prepare disaster victims for admission. So the role of the nurse, what's our role? What's the bedside nurse's role? Well, it's a vital role. during, before, and after disaster. So develop emergency preparedness plans for both internal and external emergencies. During, we want nurse leadership, charge nurse, program manager, collaborate with the medical command physician and triage officer to meet the client's needs. Again, you have to know what your patient load is, what the severity is, to allow the triage officers where they're going to fit in that grand scheme of things. Telephone trees, admits, discharges, and then after, we educate and we do safety measures. It's all about safety. So when do we call in? So one thing, if you didn't know this about nursing yet, is that, excuse me, you will be assigned a category in a hospital, if that's where you work, where you're going to have to stay sometimes for days in a hurricane. I've spent days in a hospital because of blizzards up in the New England area. Just know that that's part of nursing, that you will be part of that. You can be called in as the response team. The pre-one, you can be during or a post-event to relieve that. So assemble a go-to bag, a to-go bag. So backpack, have clothing, water, non-perishable, flashlights, pocket knife, multi-tool, cell phone chargers, whistles, disinfectant matches, toiletries, radio, duct tape, plastic sheeting, first aid kit, gloves, emergency blanket, pen, paper, medications. Because it's not only about you being at the facility, you have to get to the facility. So if something happens between then where you leave and get there, have that ready to go. Arrange for childcare, pet care, older adult care if necessary. You're going to have these contingents in place. Know where and when to report, and bring names, addresses, and numbers in case of a crisis. Again, have your own telephone tree. The facility will advise what items to bring as well, food, water, etc. And the length of time will be unknown. Again, we hope for the best and plan for the worst. So once the event is over, now what? Debrief. So critical incident stress debriefing is huge. I did my master's capstone on this. I am a firm believer in it. It is a cornerstone of aviation medicine, that we need to have a stress debrief or a debrief in general. It's a formal systematic review and analysis of a mass casualty incident or disaster. The critical event debriefing team to provide small group sessions to promote effective coping strategies. You're going to see stuff that's disturbing. Administrative review of staff and system performance during an event, determine whether there are opportunities for improvement, and if the emergency plan is perfect or room for improvement. That's all it's about. And then preventing staff acute stress disorders and PTSD following that. So signs of potential issues, physical and mental changes of stress, such as increased number of sick calls, staff bickering, call in a critical incident stress debrief team. That's part of it. That's part of the hospital's job. Encourage and support coworkers. This isn't a shameful event to have. If you ran, 3 pediatric cardiac arrests in a row, it's going to affect you, and you need to verbalize that and discuss it, and that's totally normal. Care for yourself, take breaks, eat healthy, drink plenty of water, talk about your feelings with staff and managers. Everyone's going to have a work spouse, male or female, that you, get along with. That's someone to just bounce off. They're there with you. They understand that event. Keep in touch with your family, friends, and significant others. And I have to laugh, don't work more than 12 hours. In an ideal world, don't work more than 12 hours. Keep a diary, written or typed. It's amazing some of the stories that you're going to have, de-identified, of course, to kind of help you when you reflect back on them, of opportunities for growth for you, not only professionally but personally. Thoughts, angers, emotions until it's deleted. And again, if there's a fire in there, we have our RACE. Remember that? Rescue, alarm, confine and extinguish, and pass. Pull the pin, aim at the base of the fire, squeeze the handle, sweep side to side. One race you have to win. That's it. So there's other readings in Module 9, so subsections, make sure you get those and touch upon those. And that's it, ladies and gentlemen. So not too bad, 40 slides this week. I thought that's a nice lecture. I enjoy that one. It's emergency medicine. So with that, I am going to stop recording. We did 48 minutes. Please feel free to rewatch this as your leisure. If you have any questions, as always, reach out to me anytime. I'm more than happy to answer questions, emails, and if we need to sit face-to-face, be happy to do that too. All right, have a great rest of your week. Take a deep breath, and we're back in week 10 coming up.